How do you operate in a space that almost does not exist? Cataract surgery is a surgery of space. But sometimes, the space disappears. In short eyes, thick lenses, or intumescent cataracts, the lens moves forward, the iris rises, and the anterior chamber becomes shallow. Now the surgeon must work in a very narrow space. In these cases, every step becomes more difficult. The capsulorhexis may run away. The anterior chamber is unstable, and the phaco tip is dangerously close to the cornea. Small amounts of viscoelastic escape from the wounds easily. These eyes often dilate poorly because the iris is stretched forward, frequently have closure angle. Intracameral dilating agents should be used early. First, trypan blue is essential for better visualization and control during capsulorhexis. Viscoelastic is used to create and maintain space. But the chamber is small and unstable, so pressure must be carefully controlled. Movements must be slow and central. Avoid pressing on the wound edges to prevent viscoelastic loss. Capsulorhexis must be precise. Not too slow, not too fast. In a shallow anterior chamber, pressure changes constantly. Small movements let the viscoelastic escape, the bulky lens stretches the capsule, and suddenly, the rhexis begins to run faster than your hand. And this is very important. Hydrodissection at this stage can be dangerous. Even after removing the viscoelastic, the fluid wave moves posteriorly, increases posterior pressure, pushes the iris forward, and the iris may prolapse through the wound. So instead of hydrodissection first, we debulk the lens centrally to create space inside the eye. Once space is created, hydrodissection can be performed safely. First debulk the lens centrally to create more space inside the eye, then perform hydrodissection safely. Now that space has been created, sculpt and crack is often safer than phaco chop in these cases. With careful planning, controlled fluidics, and respect for anatomy, even the narrowest chamber can open a path to vision. Additional tips include tilting the patient about 40 degrees to reduce chest pressure and deepen the chamber, and using viscoelastic to protect the cornea. Step by step, space is created, the chamber deepens, the cataract is removed, and the lens is implanted safely. Because in shallow anterior chamber surgery, success is not about speed or power. It is about patience, control, and creating space when none exists. In shallow anterior chamber surgery, space is not given, it is created.